Hello, everyone, and welcome to another edition of FitRx. I'm your host, Dr. Greg Dennis, and I am joined today by another physician. Always am excited to get physicians on the show to learn from them, especially ones who have kind of seen the light, if you will, and have come away from, I guess, traditional medicine to get more into healing medicine or functional medicine. A lot of different names for wellness medicine. But my guest today is Dr. Rudy Eberwein, MD. He is trained in internal medicine, and he is out of Miami, Florida. He has a wellness clinic there in which he will share with us what he does. He's going to share kind of his overall approach to wellness, but specifically, we're going to talk a lot today about iron, and that's actually how I got acquainted with him. As I was at a age management medicine lecture back in the spring, and he gave a lecture specifically about iron and how that pertains to, of course, those are things that we're checking on a lot of men who are on testosterone replacement therapy, which I do a lot of. And it was a fabulous lecture, and so definitely want to pick his brain today about that. So anyway, all that being said, Dr. Eberwein, welcome to the show.
So excited to be here. I've been looking forward to this.
All right. Well, let's start. I guess anytime I have a doctor on, I'm always curious to know how they got here, because we're all trained in the quote sick model of healthcare, as I call it. And unfortunately, a lot of doctors go their whole career and they never seem to get out of that. Nor really care. They just kind of have the blinders on. And then there's some like yourself who, are able to take a step back and be like, this isn't working, So tell us kind of your journey and how you got out of that. And then maybe that'll lead into kind of what you do now.
Great. So I'm originally from Haiti, and I actually started first year of med school in Haiti, because in Haiti and European countries, you go straight to med school after high school. So I did my first year in Haiti, and unfortunately, political problems started happening. That was in the early 1990s. So I came to Miami in 1991. I had to learn English from scratch. I was 21 years old. My first job was at Dunkin' Donuts. I worked there for a year, got some money to be able to go to undergrad. I did my undergrad at University of Florida, and actually did my undergrad in nutrition studies. Most pre-med majors are biology, biochemistry. I did not know this because eventually I opened a weight loss clinic, and that's what got me the preventive side of medicine. So I got my bachelor's in nutrition sciences. Then I got my MD from University of Miami in 98. And after this, I started working as a hospitalist. So I did internal medicine, became board certified in internal medicine, and started working hospital medicine. I was working the ER, the ICU, medical wards. I was doing SNFs, skilled nursing facilities. I was carrying the code beeper. I did hospice work, a bunch of things. I loved it. That's what we get trained on. We get trained on acute medicine. And we were good at it. I loved the work. I was saving lives. But it was grueling work. It was long hours. It was a lot of stress. So, and at some point, I wanted to be more on the preventive side and not just be on the acute side, not the sick care, more be about wellness, not just illness. So first thing I did in 2005, as I was still working as a hospitalist, I opened a weight loss clinic. I would go just after my rounds 2 times a week. And I was using the medications available back then, the supplement, the stimulant type medication, phentermine, phendimetrazine, diethylpropion, utilizing what I've learned in my bachelor's, nutrition counseling, behavior counseling. And I started seeing a different side of medicine. So then I went and got board certified in age management medicine with the group where we met, AMMG. And that's how I really started to understand hormone therapy. Because when we went to med school, we barely had 4 hours of nutrition education during the 4 years of medical school. Mm-hmm. I got no training on hormone. All I heard in medical school was that testosterone was bad for you and it will cause prostate cancer. Mm-hmm. So it was hard to overcome that confirmation bias that, everything that I've learned in medical school. And then I was discovering a new world of functional medicine, as you were saying, so many names: functional medicine, complementary medicine, optimization medicine, lifestyle medicine, whatever you want to call it. But to me, that is the true medicine, because it is empowering patients to not be sick. Yes, we need doctors, we need the technology to do sick care when somebody's sick, but what about preventing disease and going further than this? Not just surviving, thriving. How about getting optimized patients? Not just living and being okay, getting A+ on their report cards, right? So that's how I made that transition. And eventually, with my weight loss clinic, I was able to leave the hospital and I moved into my weight loss clinic. Then I eventually learned how to do hormone replacement therapy. So my evolution on my wellness journey, not only for me, but for my patients, is that I started using more and more tools. At the end of the day, my goal, and all of us physicians, what we want for our patients, is to give them their best results. I like it, their best life. Be the best version of yourself, whether it be physically, mentally, sexually, and even spiritually. What can we do to help patients get to that level? And so the tools that I use at my practice, I use a lot of nutrition education. I always say that the three basics of wellness are nutrition, exercise, and sleep. So I really mastered those and helped my patients master this. Then I went into the hormone and supplement world. And that's when I started using a lot of GLP-1 medication, because they're a complete revolution now for metabolic disease and for obesity. Then learn how to use testosterone optimization therapy, both for men and for women, and kept utilizing all those. I even now I'm into psychedelic medicine. I see that you had a guest that was talking about using psychedelics for mental wellness. Because really, the way I look at medicine, it's a holistic, approach. We cannot just focus on physical medicine, and we don't pay attention to the mental side or even to the spiritual side. So yes, we can be really good and have great tools for physical medicine, but paying attention and utilizing the tools we have for mental and spiritual health has been the latest thing I've been using to my practice. And then now it's been 19 years that I've been doing functional medicine. I've added a bunch of tools. I go to conferences all the time. I'm learning more. And my goal always is, wherever you start, how do I take you from point A to point B, which is optimization? And optimization is not a destination. It's a journey that I take the journey with my patients, and I try to get them to the best version of themselves.
And that's just a great summary of how we should be practicing. And I mean, I have a very similar approach as with my patients. Is I don't just want them to be average. I want them to be optimal, in everything. And man, you hit the nail on the head in the foundational stuff, or diet, exercise, sleep, and then, icing on the cake to optimize hormone replacement therapy and, peptides, there's all these things out there. So talk about, so you mentioned all that in kind of, and if there's anything else you want to throw in there about just kind of overall health optimization, do that. But I mentioned at the beginning, I met you when you had this talk about iron. So kind of in your journey of, health optimization, when did you start to learn about the importance of iron? Because just like you talked about nutrition in med school, and we don't get any of that. We don't get anything about iron either, certainly, other than iron deficiency. I mean, pretty much all we learn about iron is, well, there's a lot of people deficient, and you need to just give people iron. I mean, that's about the extent of it. So how did that come in the picture for you?
Yeah, so that was an interesting thing in my journey, because most gym bros science, right? Patients on TRT, you hear the guys at the gym say you need to donate blood every 3 months when you take in TRT. So that's what, like when you go on a lot of TRT forums, and guys are still talking about this. So as I was going into my TRT patients, I was like, you know what? Patients may be over donating. Let me start checking patients' ferritin levels. Because, ferritin, just for everybody listening, ferritin is the stored iron that's stored in the liver. So there's an iron panel. You can check ferritin. And then another panel where you check total iron, TIBC, and iron saturation. So I started checking all of those panels on my patient, more to see if my patients were having low ferritin, iron deficiency, because they were over donating. Because that happened to me many times. I've had patients on TRT that were doing well, and then all of a sudden they tell me, Doc, I'm not optimized, I'm tired, I'm cold, I think I need more testosterone. When I would check, it's because they were over donating. They would drop their ferritin below 20 and have multiple symptoms. So I would tell those guys at this time, it's not about getting more testosterone. Stop donating. Let's build back your iron stores and you will feel better. So I went looking for low iron. But what I started seeing, a lot of high ferritin levels in the 600, the 1,000. The average guy had a ferritin of 250. And I was like, wow, what is this ferritin? Because the one thing I knew about high iron when I went to med school was iron overload, hemochromatosis, that we were told is a very rare disease that you will barely see. And most things we always talk about iron is iron deficiency. So I started to look deeper into it, and there's quite a lot of articles talking about iron overload and how much of a pro-oxidant iron is. And it makes sense. In my lecture, I talk about this. Iron is an oxidant and it rusts everything. What it does to metals outside of the body, it does to our cells inside of our body. It creates oxidative stress and creates aging. And what do we try to do in our practice of age management medicine is we manage aging. And aging is basically the balance between oxidation and the antioxidants resource. When we're young, we have a lot of antioxidants. Our genetic makeup is able to really get rid of the oxidative stress that we get subjected to. But as we get older, we have less antioxidant, more pro-oxidant. So the balance turns where you have a positive, a more oxidative stress that creates cellular damage and aging. And iron is one of the most reactive elements that exist. So combining iron with oxygen is the most reactive substance inside of the body. So as I started seeing more and more ferritin levels, I dug deep. I was like, what is causing this? So many things can cause a high ferritin level. Number one, ferritin is an acute phase reactant, meaning that it will go up if you have any kind of inflammation. If you have an infection, if you have an autoimmune disease, if you have cancer, you will see a high ferritin level. So high ferritin doesn't always mean iron overload. But when you see a patient with high ferritin level and a high iron saturation, that's when you really want to suspect iron overload. So I started seeing those patients and I was like, wow, there's an issue here. And there are so many ramifications to this. But the first thing I started doing, I'm like, okay, somebody has a high ferritin, what are the consequences? And there's multiple studies that link ferritin to longevity. And the most important study that I read was the Copenhagen heart study. It's basically the equivalent of the Framingham heart study we did in the US. So that was done in Copenhagen, and they followed 9,000 people over 23 years. And they got all of their data. About 6,000 of them died during those 23 years. And they were able to really get a lot of correlation type data. And they saw one of the strongest predictors of longevity was ferritin. And it's a really nice table. I invite everybody to go and look at the Copenhagen heart study. And it showed you that if you had a ferritin above 600, median survival was 59. If you had a ferritin below 200, median survival was 77. It was a difference of almost 20 years just based on one blood test. So how important is that blood test? So when I looked at that study, cholesterol did not have such a linear association with longevity. So if I were to ask somebody, what would you be more afraid of, a cholesterol of 250 or a ferritin of 250? The ferritin of 250 has more impact on longevity than the cholesterol of 250. So that opened up my world. I was like, wow, we really need to start paying attention to this. So now I started telling my TRT patients, if you have a high ferritin level, anything above 200, start donating blood. but don't overdonate. The goal is to keep your ferritin above 50, between 50 and 100. And actually, there's another study that was called a feast study, that they looked at patients who had peripheral vascular disease, and they started doing blood donation to really drop their ferritin. And they saw that the patients who got their ferritin below 100 had the best outcome: lower risk of cancer, lower risk of advancement of their peripheral vascular disease, lower inflammation, lower risk of diabetes. So out of that study came the number that ferritin optimally should be between 50 to 100. So now on my TRT patients, and my mission is to really talk to as many functional medicine providers like you, doctors, nurse practitioners who are seeing patients, to say that an iron panel should be part of their yearly or their blood test they do regularly. It is an inflammatory biomarker that has a direct correlation to inflammation and aging, and that is so easy to manage. If it's too high, you donate blood. If it's too low, you support it. We'll talk about iron deficiency. So keep going forward. Now I'm seeing those patients, I tell them to donate, and then I started checking genetic testing to see if they have hereditary hemochromatosis. And interestingly enough, I found a lot of patients. Right now in my database, I have about 62 patients that tested positive for hemochromatosis. Remember, when we went to med school, they told us it was a rare disease. I have 62 patients, because what was interesting, the traditional view of hemochromatosis is that it's a recessive disease, meaning that you have to have both of the genes abnormal to express the disease. So having both, and the mutation, it's called a C282Y. That's the gene of the mutation. So when I would send my patients with high iron to my hematologist consultant, and they only had one out of the two genes, meaning they were heterozygous, the hematologist will tell them, don't worry, nothing is wrong with you. And I strongly disagreed with this, because the studies are showing that even heterozygous, one out of the two gene mutations, you can iron overload. And I have a lot of patients with this. And it doesn't matter how you get the iron overload, high iron is detrimental to your health. So I've had many discussions with my hematology consultants saying that you have to change the way you're looking at hemochromatosis. The Hemochromatosis Foundation, both in the UK and the US, still have not recognized that. They still say that for you to have hemochromatosis, you have to be a homozygous. You have to have both genes abnormal. And I've had many patients that I found that they have a high ferritin level and only have one out of the two. You still consider those patients to have hemochromatosis and iron overload, and they are treated the same.
Gotcha. So talk to us, if you will, kind of give us a Iron 101 lecture and for people out there when they get lab. I mean, they don't have to know how to interpret it themselves. Obviously, they're going to talk to their physician, but when they get an iron panel back, it's going to have a total iron on it. It's going to have a TIBC. It's going to, you mentioned the percent saturation, and then hopefully a ferritin level, which we've been talking about. Most people, and even doctors, when they get all that back, they're just looking at what we call the H&H, the hemoglobin hematocrit, and which I'd like to get into that as well, as far as the kind of those numbers, because I think that scares a lot of physicians when they start seeing the red blood cell go up when they're on TRT. But I guess talk about kind of what those mean when patients see that, like your total iron, your percent sat. You've already talked about ferritin. Just kind of give us a basic overview of that, if you will.
So first, I ask every patient and everybody listening, everybody who's my patient, I'm like, iron panel should be part of your lab test the same way you do cholesterol panel, because it is a risk stratification. So first, the most important number would be your iron saturation, and you want it to be below 45%. And your ferritin, the normal would be between 50 to 100, usually for women, and for men, I think it's 40 to 80. But you don't want low ferritin less than 30 usually. So that's what patients need to look at. Very important, especially on the iron saturation. You have to be sure that it is a fasting blood test, because depending on how much you ate, if you had a big steak meal the day before, you can see that your iron saturation is higher. So if I see somebody with a high iron saturation, a high ferritin, I usually will repeat them just to confirm. We never make a diagnosis just on a one blood test. And again, because ferritin is an acute phase reactant, it can be elevated if you are fighting a cold, if you have a bacterial infection going. So we repeat the blood test. If you repeat the blood test, you see that the iron saturation remains above 45% and your ferritin is above 400 or any combination of the two. You need further evaluation. The other things on the panel would be the total iron, TIBC, which is total iron binding capacity. Those things are there, but what's really important is the iron saturation and the ferritin. So if you were to be a patient and you see that you have high levels on those two, that's when you want to go deeper. You want to go first, the way we accumulate iron, number one is by diet. Are you eating too much iron? And when we think about iron, dietary iron, we think mostly red meat. So, there's a lot of carnivore diet, a lot of red meat, carnivore type diet. So you're taking a lot of red meat. So all of those patients should check their iron. Actually, very interesting little side note, Dr. Paul Saladino, who's the big guy on carnivore diet, he was on a live reviewing his labs and his ferritin was, I think, in the 500. And there was a nurse practitioner that was one in his audience, be like, "Doc, your ferritin is too high." Because Saladino went and did some research and he came on the live saying, "Oh my God, this guy's right. I'm causing oxidative stress." So he started donating and showed all of his audience that, yes, okay to eat that, but make sure you monitor your levels, right? So if that's elevated, you want to go deeper. Are you taking it too much iron? Is it by your diet? Now, the FDA, since the 1940s, has a program of iron fortification. Every flour, every carb that we eat in this country is fortified with iron to try to combat iron deficiency. It did not do a great job at combating iron deficiency, but it did a really good job at exposing a lot of people to excess iron. So where we get a lot of our iron from, it's from carbohydrate. Iron-enriched flour, crackers, cereal, bar, protein bars, all of those things have extra iron. Multivitamin, a typical Centrum has 18 milligrams of iron. The RDA, the recommended dietary allowance of iron for postmenopausal women and for men is 8 milligrams. Imagine 8 milligrams, you take one multivitamin has 18 milligrams, one slice of bread usually has 6 milligrams, and you eat iron all day long. Imagine, so an iron, that's what's interesting with iron. It's one of the only elements that our body doesn't have a way to excrete iron. Whatever your body absorbs, it stays there. The only way to get rid of iron is by bleeding. That's why women tend to be protected from the dangers of iron overload because of their monthly flow. When they bleed, they lose iron. So on average, women have lower levels of iron than men until they get to postmenopause, where they accumulate iron just like men. Actually, there's a doctor who, I forgot his name, who looked at the reason why women have less heart disease than men. And he did really nice. So we think it's mostly because of estrogen and like the sex hormones. But he made a really good case that women have less heart disease before menopause because their overall ferritin level is much lower compared to men. And there's a lot of stand with this because, again, iron causes oxidative stress. So on patients like this now, when they look at their numbers, you look at number one, is it my diet? Second, is it my supplements? Third, are people using an iron cast skillet? It's a great thing to do not to use the Teflon coating, but if you're somebody who has a tendency to retain iron, you may be getting a lot of iron from this. So trying to identify, right? Then number two would be a genetic condition. This is where we talk about hereditary hemochromatosis, and I did not realize how common that condition is. So it is the most common genetic disease in Caucasian population. So if you have Northern European ancestry, especially UK, Scottish, Irish, it can be up to 30% of the population that may have a gene for this. So if you think about the US population, that we have a high proportion of Northern European ancestry, we have 300 million for this, it's about 10% for Northern European ancestry, about 30% in the UK and Ireland. So if we were to take the US and we take 330 something million, 10% may have one or two genetic mutation. There's possibly 30 plus million people who have this. Most of them have not been diagnosed. So if you find that you have a high iron, you need to check that genetic disease, that genetic marker, the genetic testing, because that's going to give you an idea of how aggressive you need to be on your iron lowering. And my patients who have either one or two of the markers for hemochromatosis, my goal for their ferritin is to be between 50 and 80. Okay. And it's an easy test. It's a genetic testing. You can, some people even do it DNA ancestry. And they give you everything there. But knowledge is power. Interestingly enough, Hemingway, the writer, he died of complications of hemochromatosis. They found, of course, he drank alcohol, so that was another hit to his liver, but he died of complications of hemochromatosis. The musician Beethoven, they found a piece of his hair and they were able to do DNA analysis on him, and they found that he had hemochromatosis. That could explain that he had liver disease. He also drank alcohol, but his liver disease can even be associated with deafness, which Beethoven was deaf. And then throughout the history, iron overload is actually called the Celtic curse, because it originated in that northern area, the Celtic tribe, and kind of moved everywhere in Northern Europe from there. But there was a big scandal in Scotland not too long ago, where there was a royal member of the family who was diagnosed with hemochromatosis at 59 and quickly died. And then there was an outrage to say, how come we're not screening for that disease that can affect 30% of that population? So we should do the same here. Screening should be important for that.
Okay. How do, we both, I guess, are advocates for hormone replacement optimization. So specifically with men, or you, I guess, talk about women as well, how much of a role does that play with testosterone? Because we know that testosterone can increase the hemoglobin and hematocrit. What I've started doing, and I'm curious what you do, especially now that I'm checking ferritin levels, is I used to just use the H&H as a guide for them to donate. But now if I'm seeing that their ferritin level, I mean, they could have a hemoglobin of, 18 or 19, but if their ferritin is 50, I just leave it. What's your approach on that?
Yeah, so that's a whole other subject completely, right? As testosterone, one of the side effects is secondary erythrocytosis, where the body makes too many red cells, and there's different theories of why that's happening. One of the mechanism of action is that testosterone stimulates EPO, the erythropoietin enzyme, and it makes your body make more red cells. But there's another suggestion, because testosterone decreases hepcidin, and hepcidin is one of the hormones that controls the intestinal absorption of iron. And when you take testosterone, it increases intestinal absorption. So that's maybe another reason why we get a high H&H, secondary erythrocytosis, on TRT. Now, the big question is, what do we do with those patients who have a high level of hemoglobin? According to the American Association of Endocrinology, they recommend that up a hematocrit level of 54 and up is considered dangerous, that there's associated risk of clots, DVT, heart attacks, and that you should do something about it. And I actually have a friend of mine who was doing TRT, and one of his patients had a stroke while on testosterone, and he got sued because the hematocrit was above 55, and he did not mention that. So the studies are not clear on what the risk of secondary erythrocytosis are in regards to heart disease, stroke, and clots. There is a possible risk, but no studies have shown a strong link. There's a doctor at University of Miami that did a study. He looked at patients who had secondary erythrocytosis on TRT, especially if they develop it within the first year of treatment, he saw that those patients had a slightly higher risk of cardiovascular disease in the future. There's been other studies that look long-term. They saw that high hemoglobin hematocrit do not cause a higher risk. So we're kind of, us providers who see patients every day, we're kind of in the dark. What is true? What happens when you have a hematocrit above 54? So what I do in my practice, I don't like to see above 54. So as you were saying, if I see that, I usually recommend for the patient to donate blood. But if their ferritin is already on the lower limit of normal, if you donate more blood, you'll do more harm than good. So what I do with those patients, first, of course, you make sure that they have good hydration, that they're drinking enough water, and then you start adjusting their dose. You try to see, can you lower their dose? Those patients, I'll try to split the dose 3 times a week or even microdosing daily, because when you do lower dose more often, you don't have the high peak of testosterone. The high peak of testosterone is what tends to increase erythrocytosis more. So that's what I'll do with patients. I'll do different manipulations and then monitor their levels until their hematocrit gets below 54. And for my patients that I cannot get, and their hematocrit, as you said, their hemoglobin is 18, 19, hematocrit 56, 58. And a lot of those patients are symptomatic. Their blood pressure is higher. They have a heavy kind of buzzing sound, a little vertigo. They get night sweats. They sweat more. So some patients are asymptomatic, but I don't like leaving patients with such high level of hemoglobin hematocrit. And if I see that we can't resolve that, I started using a lot of the oral testosterone forms, because oral testosterone has way less propensity to increase hemoglobin hematocrit. So that's the way I approach it. It's we should pay attention to the hemoglobin because we don't have clear guidelines on what to do with it. When you hear discussion in forums, there's doctors who will tell you, I don't care if my patient's hemoglobin is 20 and their hematocrit is 60. They have more blood, more oxygen carrying capacity. Most patients don't feel good. I've actually experienced high hematocrit. So for me, I'm on testosterone therapy. What's interesting with me, it's when I went on HCG, the combination of testosterone plus HCG, that my hemoglobin went above 18 and my hematocrit was 57. There is no question that I felt it. I felt a heavy head. I kind of felt like almost, you feel sluggish, like almost like circulation is lower. And I donated blood. I felt better immediately. So I keep my hematocrit usually less than 52. That's what I want for my patients.
Okay. All right. Very good. What about with women? Most of the high ferritin I see is with men.
Yeah.
Are you seeing any of this with women?
So I've seen many postmenopausal women with high levels. Actually, my wife, who has some Irish genes in her, she's always been iron deficient when she was young and when she was menstruating, which is what we see a lot with women. And same thing, you'll usually see a ferritin below 20, iron saturation below 15. You'll see that iron deficiency. But once they stop menstruating, a lot of women, same as men, will accumulate iron, and because there's no more way of getting rid of it, they can accumulate it. So my wife also accumulated iron on, I think, 6 years postmenopause. So although she had to take iron when she was menstruating, postmenopause, now she has to donate blood. So, like in medicine, everything changes. It's personalized medicine. You need to check on everybody and see the patients through their stages of life, and monitoring and tracking numbers is the most important thing. Yeah. And something that's important, as you're talking about women, iron deficiency anemia is way more common than iron overload. And it's a more difficult problem to tackle. And worldwide, that's one of the major problems that we're dealing with iron deficiency, because when you have low iron, and if a woman is pregnant, the fetus is not getting enough iron, there's a lot of complications that can happen with this. So taking the right form of iron, and one thing that I started using, instead of using iron, we use liver extract, because liver actually has been shown to be the best way to increase iron stores, because it's the right form of iron. It carries also all of the copper, magnesium that the body needs. So when I have somebody who really needs iron, unless they need IV iron, but if it is that they just need to increase their hemoglobin or increase their ferritin, I will use tablets of liver extract, 1,500 milligrams a day. I tend to do it every other day. so that the body can absorb it more. And you'll see good improvement in your ferritin like this.
Okay, very good. Talk a little bit more about if you will. You said you really like overall wellness and kind of optimization. What does that look like to you? I mean, you mentioned the good nutrition and good sleep and exercise, but I guess be more specific, if you will, about kind of what ideal wellness or health looks like. I mean, what should people eat? I mean, you mentioned the ferritin levels, hormone levels. I mean, give us a more specific idea of what that means to you.
Well, that's a great question, because that is exactly what all of us are looking for, right? What's the goal? What is self-actualization for our patients and even for ourselves? The first thing I tell before you even talk to the provider, I ask all of my patients, and even me when I go and see my provider, I try to do really an honest self-inquiry. How am I doing? How satisfied am I with my life right now? And I look at different parts of life: physical energy, mental energy, sexual energy, spiritual energy. So on the physical energy, number one, I ask my patients to get a scoring system from 1 to 10. How do you feel physically? How's your energy level? How's your vitality, your stamina? Do you need a nap throughout the day? Are you satisfied with your body composition? Are you losing muscle mass, sarcopenia? Are you gaining visceral fat? Are you gaining body fat? So where are you in the physical? Then you go into the mental from 1 to 10. Do you have a fixed mindset or a growth mindset? Do you live in victimhood mentality, in negative mindset, in blaming, pointing fingers, or are you full of gratitude? Are you full of self acceptance, forgiveness? Where are you in this? Do you have mood issues, anxiety issues? Then we go into the sexual energy. How's your desire for sex, your libido? How's the reliability of your erections? How's your overall satisfaction with sex drive, with sexual life? And then spiritual, how connected are you to whatever feeds your soul? So once you sit down as an individual and you do that self-inquiry, you have a better way to talk to a provider to see, okay, what self-optimization looks for me is that I would like my physical health to be an 8 or a 9, and then our goal is to get 8, 9, 9.5 in all 4 of those. And optimization for me, which I call living your best life, is getting as close to 10 as we can in all 4 of those areas. We'll never be a 10, yeah, right? We're only a 10 when we die.
Yeah.
So optimization is a journey. It's a journey, not a destination. So when I meet with my patients, I like to have a starting point. Where are you now? Let's come up with a plan to get you from plan A to plan B. And the goal is plan B is not static. We're always trying to improve on where you are.
I know everybody is individualized in getting there, but can you give us, other than just, nutrition and sleep, and, can you give us some general ideas of how more people can get to those levels?
Yeah. So once, the patient and the provider have come up with, okay, this is where I am, this is where I'm going to be, what tools can we use?
Yeah.
Right. So now we have a blueprint, we need tools. And this is where, again, I built almost like a pyramid of wellness. Well, the base of it is those 3 things I said. You can never get away from this: nutrition, exercise, sleep. Let's optimize those 3 things. And this is where, like nutrition, we can spend an hour talking about nutrition. Yeah. Fasting, which diet is the best? What macros, how many macros do you get? Exercise, is it better to do cardio, to do weight training? My simple rule of thumb is prioritize protein, incorporate fasting, and focus on whole foods. For exercise, a lot of resistance training, develop your muscle, and focus on sleep. So that's the first 3. Then we go to the next level of the pyramid wellness. That's when we talk about hormones. Hormones are the most important determinant of our health. I did not realize that actually every provider, every physician should know endocrinology, because that's what determines our health more than anything. If you have, I don't care who you are, that you could be like the baddest guy with, the most fit individual. You give that person low testosterone or low thyroid, they become a shell of themselves. So I used to think that even our character was fixed in stone, that you're either a positive person or you're not. You're either a self-motivated person or you're not. But I realized it's not true. If you have low testosterone or low thyroid or insulin resistance, your behavior is different. Your personality is different. So that's why hormones become the next step after we do those first three basics. And hormones, we're talking about your testosterone levels, your thyroid levels, your insulin resistance, your cortisol levels. Look at all of this and whatever is out of range to help balance. And then we'll come back to out of range on hormones soon, right? Other step on my pyramid of wellness is supplements, because we know that now, because of our the standard American diet, right? The SAD diet, I call it, it's an abomination what we're feeding our population now.
Yeah.
It's a weapon of mass destruction. Because when you look at the amount of metabolic disease and metabolic deaths that we're having, mostly due to lifestyle. And what is lifestyle? We eat poorly. And our food source is poor. Even when we try to eat healthy, we try to eat organic, our foods have been depleted of most of micronutrient that we used to have, right? There are studies out there showing that for you to get the equivalent of the micronutrients from a cucumber back in the 1950s, you'd have to eat 15 plus cucumbers to get the same micronutrients. So we need to supplement. So, you know, us in the biohacking world, the functional medicine world, we're big on supplements because we know we can't get everything, even when we try to have an optimal diet. So supplements. And then you keep going. I look into gut health. Very important. You look into cardiovascular health. Then we can use peptides. So all of those are tools to help the body. So when I see your patients, after we do the where are you at now and where do you want to go, we look at the toolbox and we decide which one of those tools we're going to use to get you there. Then we reevaluate, we check numbers again, we do a consultation, see where you are. Okay, which other tools do I need to get you to proceed further on that wellness journey?
Yeah, no, that's great. That's a great method and way to go about it. I think we think very similarly on just, you know, the important things. So that's fantastic.
Yeah, and you know, that's what's great. I think all of us who have gone from, you know, and we don't want to bash our colleagues in traditional medicine, but it's just because you're so bogged down. You get 15 minutes in primary care with a patient. You have the suits, the companies who tell you this is what you need to do. You really don't have time to do any healing conversation or program with your patient. So when you do what we do, that you can take time with your patients, now you can do all this. And at the end of the day, it's not complicated. Is you follow this, we have the same tools available, but it's really having that conversation with the patient, empowering the patient also into letting them know they need to do their part, and then we'll bring the tools to help them get there.
Yeah, for sure. I like it. Well, good deal. Well, how can people...
Well, no, man, we're not done yet, man. I got more to talk about.
Okay.
So very important, and I see that you had an integrative psychiatrist come onto your show and talk about this. So I've been really good with all those tools, GLP-1, testosterone, supplements, you know, all of this. Then I looked into spiritual and mental health. I'm like, if we don't talk about this to our patients, we're losing 50% of wellness. So I started now doing psychedelic therapy. So we do have a ketamine clinic that really helps patients if you cannot get past whatever trauma is holding you back, whatever mindset is holding you back. Ketamine is now FDA approved for PTSD, anxiety, suicidal thoughts, addiction. So the addition of psychedelic medicine in the right set and setting and with the right counseling, it's truly powerful, because now we can truly help our patients achieve better health physically, mentally, and spiritually. And to me, this is so powerful. Once I started doing this, it made me realize that us as healers, we are truly healers, not just providers, not just physical medicine providers. We are doing light work when we do physical optimization, because at the end of the day, I always say that I do physical optimization, biological optimization, so I can bring you to psychological and spiritual optimization. That's the ultimate goal. because the ultimate goal of every human is to be the best version of who we are and as close to the vibration of God as we can. And the better your physical body is, the better your light body can become.
Yeah. No, I think that's great. And you're absolutely right. I don't think we spend enough time on emotional health and spiritual health. And I mean, you're absolutely right. That's a big part of overall health optimization. And certainly, again, as you mentioned, not to bash our colleagues, but they don't have time to get into any of that. I mean, they certainly don't have time to get into even what we're talking about. I mean, all they have time to do is refill their medicines. But, you know, even if they're able to talk about, you know, nutrition, they certainly don't have time to get into emotional and spiritual things. And yeah, the ketamine thing is very interesting. I don't know a whole lot about it, but I'm learning a little bit more. Yourself and the last guest I had, you know, they keep mentioning it, so I keep hearing a little bit more and more about it, and hearing very good things about it. So it's very interesting to me.
Yeah, man. It's you will see that's something that's going to come naturally as you keep going to your functional medicine, and you're like, because that's what we're always looking. What tools can I use to bring to my patients? Not everybody needs all the tools, but my patients, I have patients who are on, I like the trifecta of wellness tools. They're on GLP-1 medication, TRT, and then psychedelics as needed. So with my ketamine clinic, we do this with our patients. And when you optimize, so much easier. We've been able to take so many patients off of their SSRI depression medication with this. And now what we've been using a lot lately is the FDA-approved S-ketamine, the nasal Spravato, nasal ketamine. It's very mild, FDA-approved for a lot of my patients who are having treatment-resistant depression. It's a miracle. I'm getting a lot of referral from my psychiatrists and psychologists in my area because they did realize, I did a presentation for them, that a lot of young men who are coming with anxiety and depression, it could be testosterone related. Low testosterone causes anxiety. Low testosterone causes mood fluctuations, low mood, and depression. So, you know, anybody listening, if you're a provider, you see a young man, or young women also, you know, in their 30s, 40s, check their testosterone level because that may be a reason for their mood alterations.
Yeah. Very good. Okay. Yeah, so I was going to say a minute ago, I was just going to mention your website, maybe how people can learn more about you. What is your website?
Definitely. So best thing, I like people to follow me on social media.
Okay.
Dr. Rudy Best Life. So it's Dr. Rudy with a Y, Best Life. Website, they can check. I have two clinics, www.Medical Health Institute or a New You Wellness. And I started my own podcast, The Best Life Code. That's on Apple and Spotify, Best Life Code. And really my mission and your mission is let's try to empower patients, bring more awareness to this. And we need so much more foot soldiers like you and me who are going to go and really try to help patients be better. My optimism about this world now is that there's an awareness that patients are actually looking for this type of medicine. Patients no longer want the traditional sick care method anymore. So there's a much demand for that. So providers are encouraged to learn about this. And I always say that, physician, heal thyself first. Yeah. As a doctor, you should experience biohacking. You should experiment with those things, learn them, experiment them with you, and then bring them to your patients.
Yeah, for sure. Yeah, I did not realize you had your own podcast. Talk to us briefly about that. I mean, you know, I'm sure you talk, you know, health and wellness, but, you know, tell us maybe some episodes coming up and, you know, just a little bit more about that.
Yeah, so it's called The Best Life Code. My goal is exactly how to bring you your best life. And it's about physical health, mental health, spiritual health. I talk a lot about spiritual, mental health, psychedelics. And I look at psychedelics with a very scientific approach. I did a presentation recently at one of the longevity conferences, and studies are showing that psychedelics in general increase BDNF, brain-derived neurotrophic factor, which is the most important substance for neuroplasticity, to grow new cells, new neurons. So the goal always of what we do is to expand lifespan. But do you want to expand lifespan if you have bad mental health or you don't feel good? So that works together. So I've had 2 episodes I just started. So I've talked a lot about spiritual health, about testosterone. My next one is going to be on GLP-1s because I'm going to make a really strong statement right here. I love and hate GLP-1s at the same time. I love how powerful they are and how they can change somebody's life completely and improve metabolic disease. But I hate that we had to resort to this, right? So I use them. I'm the biggest user of GLP-1. I wish people could do it without. That's why there's a lot of shame about those medications, which I don't subscribe to. I'm like, if somebody can get to metabolic optimization without GLP-1, good for you. But if you feel like you need help, GLP-1s are a great tool.
They work well.
So in my statement that I put in my podcast is that GLP-1 medications are the most important medical breakthrough since the invention of penicillin.
Wow.
Period. Because what used to kill us back in the 1940s when we invented penicillin was infectious disease. What's killing us now? Metabolic disease, heart disease, Alzheimer's, dementia, cancer, diabetes. GLP-1s have an impact on all of those.
Yeah.
So it is a really important tool. So I'm going to go do a deep dive on the science and how to mitigate the side effects of GLP-1, which I've been using since 2005 when they was first FDA approved.
Wow. Okay. Well, very nice. Well, I'd encourage everyone to check that out. And Dr. Eberwein, certainly appreciate your time and expertise. Your lecture was fantastic on, iron and iron overload and all that. And I'm continuing to check, that more and more. It's funny, that came at a great time because I had just kind of started checking more of that. And then I heard your lecture and it was just kind of confirmation that I was doing the right thing.
And then once you find some high ferritin, let's get together. We'll go over them together. And, one last thing, because you had told me at the end of your podcast, you usually ask your guest, what's one thing that you would recommend to your listeners? The one thing I would recommend, everybody should know their iron status. So check your ferritin, check your iron saturation. And if there's any abnormality, don't listen to a provider who tell you, don't worry about it. If they tell you this, look for a second opinion.
Yeah. Great advice. All right. That's a good way to end it right there. So Dr. Eberwein, really appreciate your time and I appreciate everyone listening. Not sure exactly when this episode will come out, but it'll be around the holidays. So wish everyone happy holidays and we will talk to you next time.
Had a great time. Thank you.